So the ADA and the European Association for the Study of Diabetes have been collaborating since 2006 on these joint consensus statements about hyperglycemia management. They're generally come out every 3 years, and what's different this time is more of a focus on healthcare systems and social determinants of health as really the path forward towards better implementation of what we know works to manage hyperglycemia and reduce complications in people with diabetes. And the second major difference is a focus on 4 sort of major pillars to diabetes care: managing glycemia, managing weight as an equal target, cardiovascular risk factor management, and then cardiorenal organ protection, basically focusing on the use of SGLT2 inhibitors and GLP-1 receptor agonists to prevent heart attack, stroke, heart failure, and the progression of chronic kidney disease.
Okay. And what are the most pressing unmet needs in hyperglycemia management?
The biggest problem that we face today in managing type 2 diabetes is not a lack of tools. We have outstanding tools. With good access to care and good advice, almost every person living with diabetes can have excellent glycemic control and live out a normal lifespan without the expectation of disabling complications. The problem is a lack of consistent implementation of those tools, sometimes because of a lack of provider knowledge about how to do these interventions, or a lack of patient understanding that these tools actually exist, or the healthcare system not supporting everyone equally. These social determinants of health, that poverty, cognitive issues, depression often interfere with people's ability to get what they need in diabetes care.
And what can individual healthcare professionals do to improve the management of hyperglycemia in their patients?
I think the most important thing for providers to understand about type 2 diabetes management is that to get the best possible outcomes, it's really important to engage the patient as a partner in the process. The patients need motivation, they need understanding, and they need to participate in decision making around the what's next in my journey to improve my diabetes care, to prevent complications and ensure longevity with good quality of life. If you have the patient as a collaborator in that process, it makes it so much more likely that you have adherence to whatever plan you develop. The second big piece for providers is to stay up to date with this very rapidly moving field. So there's been more that's changed in the last 5 years in diabetes, I think, than probably the 100 years since the development of insulin. So it is a challenge, particularly in the primary care community, to stay completely up to date with all these innovations.
Why is individualizing care important?
Individualizing care is important because people with diabetes are very different one from each other, both with regards to their preferences, what's important to them, with regards to their physiology. Some are very heavy and some are not. Some have a huge problem with insulin deficiency. Some have a huge problem with insulin resistance. So there is a lot of heterogeneity in diabetes. And then there's also the problem related to the social determinants of health. Some have resources and some do not. So it's really critically important that we not have a cookie cutter approach that we administer to every patient, but that we have a general set of principles that, these drugs reduce cardiovascular risk, these drugs are good for heart failure and chronic kidney disease. These drugs are cheap. These drugs are associated with weight loss, so that we can tailor a general sort of menu of possibilities to what's most likely to work out well for a patient. That's a really good question. So, the social determinants of health issue is so important in diabetes and so hard to really fully wrap your head around, because it's the terrain is so broad. So a big issue is, what is the insurance scheme coverage for this patient? That is part of the social determinants of health. A second thing is, how much time do people have? What is the nature of their work? What is the nature of their home life? What kind of social supports do they have? Does their life partner support them, or does their life partner beat them? All these things are really important in helping a patient prioritize where diabetes comes out in the process. I think it's impossible to say, this one thing is the most important thing. I do think we don't adequately address these social determinants of health often. I do think it's critically important to understand whether a patient is depressed. If they are depressed, you have to address the depression, or you cannot get past it to the glycemic control. We need to understand if people have cognitive issues, and that may change over time. A patient that was doing well with their diabetes care now is not. We need to worry about these these issues that come up in people's lives that can interfere with their ability to care for themselves. It's a very tough problem, hard to boil down to one issue.
Why are cardiovascular, renal, and other complications so important for the management of hyperglycemia in type 2 diabetes?
So the focus on cardiorenal outcomes in the management, the consensus statement for management of hyperglycemia comes about really for two reasons. One, cardiovascular disease and renal disease are the most important determinants of basically longevity, hospitalizations, the costs of care in diabetes, and they're linked, meaning that if there's hyperglycemia and obesity as sort of metabolic factors, the risk of renal disease and heart failure increases. And then also, quite obviously, we have, almost this surprise that two classes of drugs that were really developed to manage glucose also seem to manage this cardiorenal risk. So there's this compelling argument that we should really focus on using these drugs, SGLT2 inhibitors and GLP-1 receptor agonists, in patients with evident cardiorenal disease, or in people at very high risk for cardiorenal disease, to reduce the complications, the morbidity, the mortality, and frankly, the very big expenses in type 2 diabetes.
Okay. Why is weight reduction so important?
Weight reduction, we have moved up over the last 10 years in guideline development, now to being sort of an equal pillar with glycemic management, largely because we have new capabilities to promote substantial weight loss. And from epidemiologic studies, from lifestyle intervention studies, and frankly from drug studies, there is the ability to lower weight by 10 to 15% or more and provide for a substantial 50% or greater probability of remission in type 2 diabetes. So it depends in that shared decision making what the goal of care is. If the goal of care is to make diabetes go away, weight loss is the path. For many people, their obesity is perceived as big a problem to them as their hyperglycemia, sometimes even greater problem for them. Again, then weight management would be a primary target. It's moved up in the consensus statement largely because we have new tools and new understanding of the benefits.
Okay. And what are the most efficient interventions that we know so far for weight reduction?
Well, the weight reduction field has moved very quickly. We've always had lifestyle management. There was a very important study from the UK called DIRECT that used intensive lifestyle therapy, fundamentally meal replacement therapy in a primary care setting, demonstrating that in the patients that lost 10% or more of their body weight, which was more than half the patients, that more than half of them had a remission of diabetes. A very important study, again, in the primary care community. We've known for a long time about bariatric surgery, where at least for patients that are not treated with insulin at baseline, again, a very high probability for remission of diabetes, at least on a temporary basis. And now with these most effective GLP-1 receptor agonists, semaglutide, and the new GIP and GLP-1 receptor agonists, tirzepatide, 10%, 15%, sometimes even more weight loss. Now for now, it's semaglutide that has a specific indication for weight loss. Tirzepatide is under regulatory review, but its greater efficacy in the studies to date show tremendous promise.
What tips would you share with other colleagues who will want to improve how they manage hyperglycemia in their patients?
I think the most important tip I would have for managing hyperglycemia is to engage in that conversation with patients so that they really are a collaborator in the process. It's their diabetes. The way I explain it to them is I don't take care of diabetes, I'm a coach. And they're the athlete. And what they achieve is based on how much they practice and basically coming up with a good plan. And really, I try and take their lead. I provide direction, but at the end of the day, you need to come up with a plan that they can live with and work with every day, potentially for the rest of their life. Frankly, these new classes of drugs, the GLP-1 receptor agonists and SGLT2 inhibitors, are wonderful tools in that they are powerful glucose-lowering agents that promote weight loss, improve blood pressure, and have this cardiorenal risk reduction. Not everybody can afford it, not everybody is going to want it, but it should be a tool that providers grow comfortable with in any case. So, I often talk about a particular patient that changed my perception about what's possible. So many years ago, I had a practice about 100 miles south of my university in a small village. It had one flashing yellow red light, not even a full stoplight. And in this little town, I met a woman who had had diabetes for 5 or 10 years, had never had good control, didn't understand anything about nutrition, was fairly physically active in her day-to-day life, but had some not very good lifestyle choices that she made. And this was a long time ago, before we had all these sophisticated technologies. But her diabetes was terribly controlled. She was fairly young. I was very worried about what her life was going to be like, and asked her if she could come to the university so we could provide her with comprehensive diabetes education. And then she came up, and the diabetes educators were quite worried that she couldn't handle a sophisticated multiple daily injection regimen because, making these food choices and understanding carb counting and all that kind of stuff was just going to be impossible for her. But the truth of the matter is, she wasn't stupid, she was just ignorant, and that with comprehensive patient education and just a bit of support on the telephone, she was able to manage her diabetes in a world-class way. And so now for more than 25 years, she's had an A1C of less than 7 and is continuing to live well with diabetes with no complications. And nobody in her little village and nobody in the diabetes education program felt that she was really a candidate for this kind of work. But it just turns out that it doesn't take extraordinary talents to be able to control your diabetes. Believe in your patient, provide them with education support. They often will surprise you. Yeah, I think the most important thing for people living with diabetes to understand is it is their diabetes. And so they do need to own the disease. And that the doctor or the nurse is really one of their coaches and one of the many resources they have to help them in their diabetes journey. The other resources being their family members, their national insurance scheme, their workplace. And just like if you owned a painting that you thought was particularly beautiful, or anything that you own you want to take care of, you need to make sure that your coaches, your doctor, your family members, your support system, your employer, everybody's got to be on board with your diabetes. Sometimes it means that you need to be out there and say, well, I have diabetes, I need to do this for myself. But in any case, I do think you need to own your diabetes, recognize that you can live out a totally normal life expectancy without disabling complications, but it does require you to work towards good control. We have great tools, and your providers can help you understand them and get access to them, but at the end of the day, it's your diabetes. You're going to have to do it.
Thank you.
It's a pleasure.